Hello, welcome to my ACP presentation. My name is Pooja Singh. I'm a first year internal medicine resident at Advocate Illinois Masonic Medical Center, Chicago, Illinois. Today I'm going to talk about an unfamiliar tale of cold agglutination and pulmonary embolism. To introduce cold agglutination, it is a rare form of autoimmune hemolytic anemia accounting for 15% of all the cases with an incidence of 16 million cases per million people year. Cold agglutinins are autoantibodies that recognize self antigens on RBC, causing agglutination, resulting in hemolysis. One of the rare complications of this process is thromboembolism. Now, I am going to present a case of cold agglutinins causing pulmonary emboli in a young male. This was a 26-year-old male with no significant past medical history presenting to the ED with acute onset dyspnea on exertion and fatigue since 1 week. He had no similar complaints in the past. On arrival, he was afebrile with a heart rate of 120, blood pressure of 153 over 100, respiratory rate of 20. He was saturating 92% on room air. He was an obese male with a BMI of 31. Conjunctival icterus and mild hepatomegaly was remarkable on physical examination. Labs were significant for a hemoglobin of 6.5 with MCV of 90. Platelet count was 470. Total bilirubin was 3.8 with direct accounting for 0.6 and indirect for 3.2. D-dimer was elevated up to 6.06. He was tested negative for COVID PCR. EKG was significant for sinus tachycardia. Chest X-ray was within normal limits. Due to elevated D-dimer, CT chest with contrast was performed. Multiple bilateral segmental and subsegmental pulmonary artery emboli were found on imaging. The patient was immediately started on high-intensity heparin drip. As hemoglobin was 6.5, type-in screen was performed, which revealed IgM-positive cold agglutinin antibodies, thereby giving a diagnosis of cold agglutinin disease. The patient was treated with warming blankets to maintain a core body temperature of 38.6. Packed red blood cells were warmed before initiating transfusion. Even after transfusing 3 units of blood, there was no significant increase in hemoglobin. Therefore, plasmapheresis was initiated with hematology-oncology department on board. Extensive oncological, rheumatological, and infectious workup was parallelly started to find the etiology of cold agglutinin disease. The results were inconclusive. Over the course of hospital stay, a baseline hemoglobin of 7 was observed. Based on recently updated trials on primary cold agglutinin disease treatment, our gentleman was started on rituximab and bendamustine therapy. He was discharged on the same therapy and appropriate anticoagulation therapy. On follow-up, 4 weeks later, his pulmonary embolism was resolved and his IgM titers decreased from 3 plus to 1 plus, thereby maintaining a baseline hemoglobin of 10. Now, when we look at the mechanism of thrombosis in patients presenting with cold agglutinin antibody disease, there is RBC antigen and cold agglutinin antibody mediated complement activation causing lysis of RBC. This lysis leads to release of free heme, reactive oxygen species, and ADP into the blood, which causes platelet activation, resulting in coagulation pathway activation. There is also impaired vasodilation and endothelial damage, facilitating thrombus formation. In our patient, thrombus formation must have likely been in the pulmonary arteries. Risk of thromboembolism in patients with cold agglutinin disease is higher compared to the patient without the disease. The above case of our patient without any significant history getting diagnosed with pulmonary embolism with incidental finding of cold agglutinin disease changes the diagnosis from unprovoked to provoked pulmonary embolism, thereby changing the treatment plan of anticoagulation. In conclusion, discontinuation of anticoagulation at the end of 3 months in this case depends on the risk factor of thrombosis, the bleeding risk, and the patient's preference. Thank you.